Hi everybody. This is the last set of slides for screencasts for this week of October 14th. I guess it's 13th, sorry. So this involves what are called neuromuscular techniques. Now, we've talked about a few things that have related to the term muscle and the terms neuro, but we're going to redefine here just a bit. So when we're looking at neuromuscular techniques, neuro refers to the neurologic control of muscle length and the associated level of resting tension. So we are saying basically these techniques affect that. Muscular, of course, in the context means that while applying the technique, you are palpating and applying direct forces towards or on the identified or target muscle for the treatment. In general, these neuromuscular techniques are used to assess and treat. Obviously, our assessment would be within the context of the 5Ts, and then treatment, of course, because we do affect the direct muscle that we've identified, possibly as the primary problem or associated muscles around it. The effect level of resting muscle tension, so we affect it in terms of trying to lower muscle tension, so therefore it can reduce pain and possibly, or more often, restore range of motion and joint mobility. So if there's a reduction in range, of course, then these type of techniques should improve range of motion. Of course, it decreasing pain as well because it's affecting the neurological system. These techniques can also be used in the treatment of trigger points. We'll be getting into that a little bit later in clinical anatomy, but understand that these trigger points are sore spots on muscles or points where we do have referral patterns and can be quite limiting. We've already looked at referral patterns in clinical anatomy 1, and you have a sense of where they are. You can also increase perceived relaxation and decrease perceived anxiety. So the other thing in these neuromuscular techniques, they do affect neurological intervention, this neurological control from the nervous system to muscle tone, but there's also the mechanical part of it. If you remember, mechanical means any kind of technique that pushes or stretches or changes position of soft tissues. So the mechanical effects of these neuromuscular techniques can be caused by compression and stretching of the direct muscle fibers. Also, tension applied to connective tissue wrappings. So I've sort of alluded to it a bit again in clinical anatomy, where when we look at a muscle package, and we call it biceps brachii, for example, there is connective tissue wrappings all around that muscle, and those connective tissue wrappings also invaginate deep into the muscle itself, so they have a very intimate connection to the entire muscle package. In this case, I'm saying biceps brachii, and we can affect those connective tissue wrappings through these techniques. As well, these techniques also promote movement of fluid in vessels that pass through the muscles. So we do get metabolites as a result of the cell's metabolism or metabolic processes of muscle cells. There are fluids that are created in regards to those metabolic processes that occur in skeletal muscle, and we promote the movement of that out of the muscle tissue, or sorry, neuromuscular techniques or your use of it promote this fluid passing through the muscle. The reflex effects of it, so that's the thing about neuromuscular, hence the reason why it's called it has mechanical effects, but it also has reflex effects, which are part of the neurological system. So the use of these neuromuscular techniques stimulates proprioceptors. Now, we haven't talked much about proprioceptors, maybe just a touch, but please understand that proprioceptors, they're part of that feedback mechanism. Remember, there's something that reads what's going on at any given time. Could be temperature, could be water levels, and so forth. All of those sensors are called proprioceptors. So they're measuring something. In the case of muscles, these proprioceptors are called muscle spindles and Golgi tendon organs, and they measure tension in muscle and length of muscle. So you're stimulating those to try to lengthen a muscle by calming down a muscle spindle, or decreasing tension in a muscle or tightness in a muscle by stimulating the Golgi tendon organ. Also, in terms of different philosophies, such as reflex areas or meridians, so reflex from reflexology, meridians from traditional Chinese medicine, you can, through these techniques, stimulate especially in the feet, for example, reflex areas or the of reflexology or the meridians in traditional Chinese medicine. So when we look at what these techniques are, these include broad contact and specific compressions. Also, numerous forms of what is called petrissage, and there are 5 in total. I'm not sure how many you have or have not taken in lab, but they range from muscle squeezing, muscle wringing, muscle C-kneading, and broad and specific kneading, getting a little more specific into structures or parts of a muscle that you're kneading. So we have squeezing, wringing, C-kneading, and broad and specific kneading. And the last one is muscle stripping. So these are the particular types of techniques that we use. So let's do compressions first. Oh, compressions are exactly what you might think, and that involves compressing. So how do you perform them? The first to understand is they're non-gliding, so we're not using lotion sliding along the tissue. You can go from broad contact, such as using the palm of your hand or the ulnar border of your hand, or you can also do it specifically using smaller contact, such as a thumb or an elbow. Of course, elbows, you're going to hear a lot about everybody uses elbows. We don't usually tend to get into using those in semester 1. You have a whole lot more to learn before you consider using elbows. And that's probably been explained to you as well in lab. Now what you do is you apply the pressure and it's perpendicular to the muscle. So we have to think about, what do we mean by perpendicular to the muscle? We have to understand that the muscle fibers run from attachment to attachment. And if we're running perpendicular, we're at a 90-degree angle to those fiber directions. If we were running from attachment to attachment, that would be running what? I'll let you think about the word. Okay, be parallel. But the pressure here is perpendicular to the muscle, so we're working sort of across the fibers. We want to reinforce the body part because we're applying pressure to that body part. If we don't reinforce it, it obviously is going to move and maybe excessively, which could cause injury. So we want to reinforce it so it doesn't move too much when we apply the technique. It engages the muscle at various depths. Obviously, lighter would represent affecting the more superficial fibers of the muscle, and a heavier form of compression would, of course, include or invest the deeper structures or the deeper parts of the muscle. Now, what do we use compressions for? When resting muscle tension is high, we can either sedate or lower the tone or the tension, in the muscle, or if we want to stimulate it, we can increase muscle tension. And again, the idea being, pre-sporting event, we would stimulate muscles. Post-event, we would use sedating forms to calm the muscle down. Compressions are also great for trigger point work. Also, sports massage compressions get used a lot in. And they can also, because we're looking at muscle tension, they can be used to assess tissue, within those 5 T's. So we can see here the massage therapist on the left is using a broad contact to the gluteal region, pushing against the muscles. The gluteal muscles, if you think about perpendicular, run from this point in the upper leg and come up to the top in the sacral area. So the fiber directions are running this way, and we can see the direction of the pressure is running perpendicular to it. Now that's sort of using that almost, a very large area of the forearm. Whereas the therapist on the right side of this slide, you can see is right down to the tip of the olecranon of the elbow. So a much smaller contact area for the therapist. And so therefore it's known as a more specific contact. And understand, and I said this earlier, broad contact is perceived by the patient to be not as invasive or deep, whereas very specific contact is perceived to be very specific and very deep. These two individuals may be using exactly the same pressure. On the left, the patient will perceive that as not so deep, but on the right, the patient will perceive that as very deep. So one always has to be aware that when we're moving to specific contacts, we have to be very cognizant of what kind of pressure we're using, also making sure that we're checking in with our client at all times to make sure that that pressure is appropriate for them and not too forceful or not too deep for them. The next is called broad contact compression. So again, this is a non-gliding technique that engages the client's muscle. The pressure and release of the stroke are perpendicular to the surface of the client's body. It is delivered with a broad contact surface such as the palm, and quite often we use it in sports massage. It can assist expiration when applied to the rib cage along with rib mobility, so we can actually affect how much the rib cage can move and help with expiration. Again, through fast or slow, it can be either sedative or stimulating. Broad contact can also be used to assess the level of muscle resting tension, and you can use it to treat resting muscle tension to lower it, and of course along with that you will decrease pain. And if you're lowering tension in a muscle, it should be able to get longer. Therefore, you're restoring and bringing the joint that the muscle crosses, you're bringing it closer to normal or bringing back normal range of motion. All general and local contraindications for mechanical techniques apply. That can be seen in on your Andre, Chapter 5. Some common considerations where you need to make modifications would be osteoporosis. I'll let you think about why that would be a modification required. Well, what would the modification be? It would be the amount of pressure that you applied, because you could be pushing a muscle down on bone, and if that bone is weakened, you could cause a fracture if it was weak enough. If the patient is taking anticoagulant drugs, or what you might call blood thinners, again, the pressure may cause some micro damage to the tissues, and under normal circumstances, there wouldn't be any issue with that. But if someone is on anticoagulants, you could get interstitial bleeding, which would result in very large bruising and uncomfortableness for the patient. The other thing is, if a patient is in acute spasm, we can apply it, but it has to be done with caution. So some effects that we can consider with these broad contact compression techniques is through the mechanical effects, meaning moving the tissue. We can increase perfusion, so diabetics tend to have perfusion issues when looking at the distal parts of hands and feet, so the compression can promote more perfusion to the tissues. Another area is if someone has tight ribs, for example, or muscles around the ribs themselves, we can mobilize the ribs, which can result in more movement and therefore being able to expire and inspire a bit better for a client with certain conditions. To perform, we don't use oil. The technique is effective through clothing. This is why it can quite often be done during sports massage, where you're actually treating your clients when they're all dressed for their sport. That can be done there. We use large contact surface areas such as fists, palms, and forearm. As we stated earlier, we compress perpendicularly into muscle bulk or onto rib cage. We hold that compression from anywhere between 0.5 to 5+ seconds, depending on what's happening. And when we compress, we smoothly compress in. And when we're done and we smoothly release out. So never ever herky-jerky, smoothly in to compress, smoothly out when done. As I stated earlier, when the rate is slower, it becomes a sedative technique. And when you're applying the technique faster, it becomes stimulating. Again, sedative for post-event if you're doing an athlete, faster for pre-event. Specific compressions. So they're non-gliding techniques as well that the therapists apply with a specific contact surface to muscle, tendon, or connective tissue. So again, through your assessment process, you identify a structure such as a specific muscle, or the tendon of that muscle, or the connective tissue within the context of where the problem is. Compression and release occur in a direction, again, that is perpendicular to the target tissue. The compression is often sustained, so increased or decreased pressure determined by client tissue response. I used this technique quite a fair bit in my practice, and what I always try to get students to get consciously aware of is when you apply the compression, to get a sense of how much the patient's tissue is pushing back at you. And you don't want to try to win the fight immediately. You will apply pressure and you will feel the resistance of the tissue and you will sustain it. And you will just stay there. And eventually what will happen, the muscle tissue or the fascial tissue, it will give way to you. And then you will move in a little bit more deeply into that pressure again until you feel resistance. We can talk about this in class. I can show you a little bit of it, but this technique works very, very well, that the patient doesn't perceive it as being too invasive or too uncomfortable, and you're listening to the body and of course to the patient themselves, but you're listening to the tissue that you're touching. What resistance is this tissue giving you or not giving you? So specific outcomes and uses to these specific compressions. These specific compressions can inhibit what's called neuromuscular tone in neurological conditions like spasticity. So for example, you can get certain, like say for example, you cerebral palsy, where you've had significant damage done to the motor centers of the brain, and you have the patient who is has in sort of what's called flexure spasticity, where the arm and the hand is curled in, or into plantar flexion, and you can use these compression techniques to lower the tone and possibly open up a hand or get a foot in an appropriate position and so forth. It's also used for complex reflex effects in reflexology and Eastern approaches to massage, such as acupressure and shiatsu. Those are techniques that are related a little bit to traditional Chinese medicine, but they're quite often used by us as well. It also reduces activity and symptoms of trigger points, and this is the way I treat trigger points, is with specific compressions. I literally, compress into the trigger point to release it. So remember, trigger point, referred pain, quite often referred tenderness. You can get motor dysfunction where it will twitch, and an autonomic phenomena where you may get sweating around the area. But we'll get into that a little bit more in terms of trigger points when we're in Clinical Anatomy 1. All general and local contraindications for mechanical techniques apply, and of course those are within Chapter 5. We've talked a bit about those. All cautions related to trigger points apply, and there'll be a slide of this presentation there. Also be aware of possible reflex effects that can occur with reflexology and Eastern approaches to massage, as I said, such as acupressure and shiatsu. So where would you use it? Hands and feet for perfusion. So if you were trying to flush fluid out or get fluid in, which would include blood with oxygen, we use it in the shoulders, so compression can be used up in the upper traps. How would you modify or contraindicate it? Something, because there can be deeper, more invasive techniques, things such as hemophilia, so bleeders, those who are on blood thinners, if there's an area of acute inflammation or a known thrombus or clot in the tissue, we would either, hemophilia would be a contraindication, acute inflammation would be a local contraindication, a thrombus would be more of a modification of position and area and so forth. Okay, petrissage. Now this is a traditional term that I was trained in, even though the terminology's changed a bit. So we're looking at these neuromuscular techniques, and petrissage is one of them. So this is a group of related techniques that repetitively compress, shear, and release soft tissue, primarily muscle in most cases. And within the context of the techniques, you have varying amounts of drag, lift, and glide. And you've probably started doing them in lab at this point. The 5 main varieties are muscle squeezing, which the name kind of tells you what it is, ringing, picking up or C kneading, broad contact kneading, or specific kneading. So let's do, its outcomes and uses. And I'm pretty sure you've done a lot of these in the lab. Again, when we get together next week, if you want to review a couple of these, we most certainly can. Outcomes and uses. It helps reduce anxiety, improve immune function. It does reduce pain. There's a good chance it reduces levels of resting muscle tension within the context of it. And even, because you're mechanically moving tissue is a good sign, it probably improves fluid return as well. And it has a great effect on things such as headaches, trigger point syndromes, low back pain, and fibromyalgia. And they're very good for all of these issues. Contraindications and cautions, again, they any mechanical technique, they're in Chapter 5. Some common considerations, again, osteoporosis, right? Weakened bones, we have to be careful with pressure. Anticoagulant drugs, again, they may bleed if they get too deep. Spasms, we have to be cautioned with them, and active trigger points as well, in terms of more of a caution than a contraindication. Osteoporosis would be a local contraindication. If they're on anticoagulant drugs, that would be a general contraindication of deep work because there's a high chance of causing bleeding and bruising. So when we perform them, we don't use oil. Again, because we don't need oil, it is a very effective technique with clothing or through clothing or over clothing. Grasp, squeeze, and hold the muscle belly with the whole hand. You can see this technique here, and this is a muscle called sternocleidomastoid. You can see I kind of call it a hook technique. You can see the second finger is a broad area within the muscle, and the thumb is wrapping around, and the technique is applied through squeezing this structure, and this is known as a pincer grasp, and you can see how short it is by how much it sticks out here and here. It's really good to, with any kind of muscle. So when we're doing a whole or a very large belly, we can use grab and squeeze with the whole hand. And if we're doing a small muscle, as we can see here in the diagram, you can use the thumb and index finger to do your grab. But ultimately, you're squeezing the muscle between your fingers, whether whole hand or specific thumb and index finger. So stop and think how we use this. So your client has an increased resting tension in the right sternocleidomastoid. What are its attachments? Well, its name kind of tells you. We haven't done it yet. We're going to be doing it this week. But sternocleidomastoid, its name tells you everything. The sternum here in the manubrium. Cleido means clavicle up here. And then mastoid means up in the mastoid process. So its actions, it is a contralateral rotator and an ipsilateral lateral flexor. I'll let you think about that. Contralateral rotator, ipsilateral lateral flexor. So this is the technique to use with this pincer. And then we would squeeze it to try to reduce tone to make it longer. The next one is called wringing, and it's just what you think, like wringing out a cloth. So we start with the hands on opposite sides of the circumference of a body segment, such as the calf, the thigh, or the back. You slide your hands towards each other, compressing, lifting, and shearing the muscle between them as they pass. So you'll actually see sort of an S configuration in the tissue if you're doing it correctly. You repeat going the opposite direction. So in the case here, you can see in the diagram, this right hand in number 1 is moving medial, whereas the right hand is moving the opposite lateral. And then in the second movement, the left hand is going lateral and the right hand is going medial. So we're going back and forth in the opposite direction. There is some compression here. So this isn't just a slight effleurage type of movement. You are mechanically moving the muscle. So there should be a bit of a deeper grasp or a firmer grasp on the tissue when you're performing it. You continue to repeat with your hands going in opposite directions, wringing back and forth. And as it says here at the bottom, you need to use enough force to shear the muscle, just not the skin and the fat. Picking up, in this case here, you're abducting your thumb so that your hand forms a C shape with the 4 fingers grouped together in adduction. So, you've got the C shape between your thumb and the rest of your fingers. And you can see the C shape here between the thumb and the fingers. There's the C shape. This is why some texts call it C scooping or C kneading. You grasp and squeeze the muscle while gliding your hand in a centripetal direction. So you're sliding down this direction and you're lifting the muscle off of the underlying bone. So sliding down, lifting the muscle off the bone. You perform that this direction, again, distal to proximal, and then you somewhat relax. You don't break contact. You slide back up to distal, and you perform the C, picking up again from distal to proximal. So working towards the axilla here. So we glide back to the starting position with minimal pressure, and then repeat with the increased pressure that picks the muscle up off the underlying bone, and then we gently glide back again. The next is broad contact kneading. So you use a broad contact such as the palm. You compress into the muscle and glide centripetally. So you can see how the hand is moving up and out. You lighten the pressure and return. So the push is in, up, relax, and slide back. And you can see in the circles here, the therapist started here, push, relax, glide, back. Push, relax, glide back. You can also do it largely this way. And I'm sure you've done this in class and lab as well. Again, please feel forward to bring some of this stuff forward next week when we're in class. The pressure strokes and return strokes form circles or ellipsoids that are oriented along or across the fibers of the different muscle layers. To access deeper muscles, you use more body weight to get down in through controlled leaning. So again, if we think of superficial, deep, superficial, you would do it lightly, then deeply, and finish lightly again on your way out. Specific kneadings, this is where rather than using the full palm, we are using fingers or thumb doing exactly the same thing. Compress into the muscle, then glide centripetally, and we lighten the pressure on our return. Pressure in, do the circle, lighten back. Instead of palms, we're using fingers and or thumbs. The pressure strokes and return strokes form much smaller circles or ellipses. So fairly large circles here when we're using the broad contact palm, much smaller that when we're using thumbs, and this could be used in the feet or thighs, wherever. You choose a lot of different parts of the body. Now we stabilize by having the heel of the hand in contact and or reinforced to support the small contact surface. So you can see here that, you could use broad contact, but in the same position, you would still have the heel of the hand in the same position, but you'd slightly flex the fingers, so it's the tips of the fingers that are going in. So full palm is broad contact, fingertips would be specific kneading, okay? So you stabilize it by that heel. We can see here we've got small circles and relaxing back in here in the foot. We also see it here in the thigh where, we're working a particular muscle within the quadriceps possibly, right? So which of the better shows proper ergonomics? More this one as compared to this one. And I'll ask you why. And I'll ask you to bring the question forward in class next week so we can have a discussion about it. This is not as good a set of ergonomics by the therapist as this one. And I want you to bring forward why you think that next week. So in practice, and of course, these are the techniques, you're going to use them all when you're in the lab setting, petrissage, muscle squeezing, ringing, and so forth. And you have to think of what contact surface did you use when you were placing your hands in it? What pressure did you use? And then, of course, you need your fellow peers, maybe the client on the table, possibly your lab person, to look at your ergonomics, to check in and make sure that you're doing them correctly. Our next neuromuscular technique is muscle stripping. So this is a very slow and specific gliding technique, and it's applied from one attachment of a muscle to the other. So in red here, which is spelt wrong, anatomy knowledge is a must. So obviously what's key to this technique is full knowledge of where your two attachments are in any specific muscle that you're stripping. So you're always moving from one attachment towards the other. Therefore, you absolutely need to know where those attachments are. This is where palpation comes in. So you know the attachments, and you're going to palpate it. And of course, you've talked about this. I know you're going to confirm your palpation, and that's going to give you a sense where the muscle is. So between that palpation, that confirmation, and your knowledge of attachment, this is how you can safely apply muscle stripping. So its effects, it's used to decrease trigger points. It's not my favorite form of decreasing or getting rid of trigger points, but it is a very viable technique to use to remove trigger points within muscle and fascia. It does have very similar effects towards petrissage and neuromuscular techniques. It also has similar effects as direct fascial techniques, and direct fascial techniques will be next semester. So outcomes, it affects muscle tension and therefore improves range of motion, and in most cases will increase the length of the muscle and therefore decrease pain, although the technique can be quite uncomfortable. It does reduces activity and symptoms of trigger points, which remember trigger points, referred pain, referred tenderness, motor dysfunction, and autonomic phenomena. So it can help reduce those. To perform it, you used reinforced fingers or thumbs or an elbow. Now, again, what are the differences between that? And the hint will be contact percentages. So when we are looking at a finger versus a thumb versus an elbow, which of the one has the smallest contact? And remember that I did say that the smaller the contact, the more the patient perceives depth. So we have to be aware of that. It compresses the fibers at one end of the taut band. So we find a taut band, we compress at the end of that taut band, and we glide very slowly and with equal pressure along that entire band all the way to the other end of the muscle. Repeat going the other direction. So we go from one attachment to the other and then back again from the attachment you finished back to the other one. Underline here, the most important part of this technique is you move slowly. And the second most important part is that you maintain equal pressure along the band. Right now, of course, we're going to be checking in with the client. If you get into a part of that band that's very uncomfortable for the client, you're going to lessen your pressure as you perform the technique. This is one of those techniques you really, really have to be checking in with your patient to make sure they're in an appropriate level of uncomfortableness that you can continue it. So you move through, and if you find that the resistance disappears, if you find also the patient doesn't feel any discomfort with it, but you still feel some tautness in that muscle, then you're going to go a little bit firmer with the pressure and repeat. That is optional because you may not find the taut band decreasing, but you will still over time reduce that tautness. Obviously, we follow the principles of massage first. So if we think about superficial, deep, superficial, you would be doing lots of superficial work way before you started doing muscle stripping. So you would be preparing the tissue to take a deeper technique. And of course, when you were finished your stripping, when you felt that you had achieved what you wanted or got the best you could, then we finish off afterwards, again, performing something superficially that helps drain the area and also helps gets the tissue back to some normality after such deep work. As I said earlier, pressure can be light to heavy, really depends upon the depth and the pain tolerance of the client. It does engage the muscle and related fascia, so it's also a great fascial technique. And in the case of these previous neuromuscular techniques as compressions that worked perpendicular to the muscle fibers, muscle stripping runs parallel to the muscle fibers. And this can take several seconds to minutes. You could be moving so slow and the muscle so large, you could be doing this for 4 or 5 minutes, or in some cases, you could be doing it quite quickly. Contraindications, of course, all general and local contraindications for mechanical techniques apply. Again, chapter 5. When we're looking at significant contraindications, hemophilia, obviously if someone's a bleeder or they're on anticoagulants, we wouldn't do this at all because the likelihood of bleeding and bruising would be extremely high. We never ever apply deep techniques over acute inflammation or infection. If you have a blood clot there, of course you wouldn't do it. And again, because of osteoporosis, we'd have to be very careful with pressure. The same with spasm. We have to consider antagonists and synergists when treating. So, if we have a muscle that's extremely taut and we want to apply muscle stripping, is it likely that synergists could be somewhat affected as well? I would say yes, because in the sense of an agonist, if it's uncomfortable, tight, and sore, then quite often, without the patient even realizing it, they will turn to the synergists to do the work. And if they're synergists, they're not meant to do that much work, and then they become a problem as well. Also, antagonists, we have to consider if what the state they're in relationship to the muscle that you've identified as being the problem. You also have to consider perpetuating factors. So you can strip a muscle all you want and get it feeling better for that treatment. But if and I talked a bit about this last week, if you remember, if their posture is bad or what they do at work isn't very good, you can do all the treatments you want, but you have to work on those other things that are the cause of the problem. Otherwise, the problem isn't going to go away. So it could be a structural asymmetry where there's something happening between weakness and tightness of muscles so that things aren't lined up appropriately. Or it could be something that they're doing at work or on the job that they're doing repetitively that can be the cause of the problem. Treating trigger points using specific neuromuscular techniques. So this is stripping, specific compression, and trigger point release. So I've alluded to this a couple times in the introduction of these techniques. I'm going to just go a little bit deeper in terms of treating these trigger points using these neuromuscular techniques. Now you've seen this a little bit in some of the slides that I've used in clinical anatomy, where we talk about, where the muscle is, X marks the spot where we find trigger points, and then we have referral patterns. So for example, we're looking at sternocleidomastoid. It has two heads. It has a sternal division, which arises from the mastoid process to the manubrium of the sternum. And then we have a clavicular division that again arises from the mastoid process but goes to the clavicle. Each of those heads has their own specific trigger points within the belly and their own referral patterns. So you'll see here that in the sternal division, any trigger points here can go to the back of the head, to the vertex at the top, and a long line over the eye into the cheek and chin and so forth. When we look at the clavicular division, we get what I call the headlights, so two intense spots over the eye, top of the eyes, in the ear itself and the back of the ear. So this is, again, something I talked about in clinical anatomy as to why it's important to understand the trigger point patterns so you can help, clinically resolve anything your client might have or bring in if it is in fact from a trigger point. So the question is then, how do we use these techniques to resolve these trigger points or remove them so that the patient no longer has these symptoms? So we have to remember, we don't remember because I haven't taught it to you yet, so we'll talk a bit about it, I apologize. A trigger point is considered a hyper-irritable area in skeletal muscle that is associated with a hypersensitive and palpable nodule located in a taut band. So when we palpate a muscle, if it's very sensitive or very uncomfortable for the patient, and within that muscle there's an actual nodule, so the muscle's tight, taut, shortened, it's hypersensitive and a nodule, it's likely a trigger point. The area of that palpable nodule is painful on compression, and when we do compress that nodule, it can cause things such as referred pain and tenderness, which we're seeing here. So pain usually gets represented as a very intense color here, where tenderness is the stippling area here. You can also get motor dysfunction, which means when you compress the muscle, it will twitch like crazy with minor contractions. And you can get autonomic phenomena such as sweating in the area or even goosebumps. I don't know what happened there, I apologize. Hang on, sorry, here we go. So we can see here that, there's a whole bunch of them here. There's lots and lots and lots and lots of trigger points that we can find in the body. I'll sort of throw this on here for you.
Many people suffer from pain and physical problems. Very few people know that these problems are often related to trigger points. Understanding and treating trigger points helps to lessen pain and improve overall health. This video is a short explanation and introduction to the trigger point. A trigger point is a small muscle contraction which can be felt as a small nodule. Pushing on this nodule is very painful. Trigger points can exist in each muscle of the body. Multiple can exist at the same time. Often both sides of the body are affected equally. The trigger point keeps the muscle tight and weak, restricting the muscle's range of motion. A trigger point can actively cause pain, or it can cause no pain unless touched. Mostly this pain is sent to a different area of the body. This is called referred pain. Referred pain can make finding and treating trigger points difficult. Luckily, referred pain follows typical patterns that have been well documented. Let's take a closer look at the trigger point. A trigger point lies in a taut band. A taut band is a tight strand of muscle that feels like a cord, easily mistaken for a tendon. The trigger point itself can be felt with the fingertips when its location is superficial. The size varies from a pinhead to a pea. When we continue to zoom in, we can see the muscle fibers that make up the muscle. The lines on the muscle fibers represent sarcomeres. Millions of sarcomeres, acting like tiny pumps, have to contract to create movement. Sarcomeres can become overstimulated and unable to release their contracted state. This knot of contracted sarcomeres shows a segment of the fiber that has become shorter and wider because of this. But also a different segment now becomes stretched by this tension, shown by the greater distance between the sarcomeres. Together, multiple of these sarcomere knots form the trigger point. The stretched segments of the fibers give tightness to the taut band in which the trigger point lies. When sarcomeres are stuck in contraction, blood flow stops in the immediate area. The resulting oxygen starvation and accumulation of waste products irritate the trigger point. The trigger point responds by sending out pain signals. In return, your brain will stimulate you to stop using the muscle, which further shortens and tightens up the muscle. Trigger points will not release without proper treatment. The most effective way to treat a trigger point is applying deep stroking massage directly to the trigger point. This can be done without the help of others. Deep stroking massage means performing a series of deep strokes across the trigger point nodule. In this example, a rubber bouncing ball is placed between the body and the wall to reach the trigger point in the lower trapezius on the back side of the body. You can see the ball moving slowly and deeply in short strokes from one side of the trigger point to the other. Series typically consist of about 8 to 12 strokes and are performed about 5 to 10 times a day. By using deep stroking massage, you are milking the trigger point, so to speak. Blood and lymph fluid is moved out containing waste generated by the contracted muscle fibers. Each time you move over the trigger point and release the pressure, fresh blood immediately flows in, bringing fresh oxygen and nutrients. It may take several weeks to return the muscle fibers to their normal state and fully release the trigger point. Trigger points which have existed for a long time will take a lot of treatment, but often results can be achieved in days, meaning less pain and improved mobility. You can find references to more in-depth information about trigger points and their treatment.
Okay, so some things to think about there are exactly that. The other thing, though, to understand is, yes, the patient can use a ball to self massage, but where he said you don't need outside help, I would disagree with that. The feedback's different. If a therapist does it, it tends to resolve better than the client doing it. But certainly that ball technique, for example, would certainly be something a patient could do to help prevent that area from coming back into a trigger point. We'll spend a little more time into that in clinical anatomy. And as you move through the program, you'll also talk a lot more about them and techniques to resolve them. So when we look at trigger points, there are certain types of them. So trigger points can be classified first as an active. So this type of trigger point, an active trigger point, produces pain in its characteristic pattern when the patient isn't doing anything. Could be lying in bed and having that pattern. Whereas a latent trigger point produces pain in the characteristic pattern only when it's palpated. So an active is one that can still have the referred pattern at rest, whereas a latent one is one that you will touch, and I think I did that in class one day with one of your fellow students in the shoulder, where when I pressed on the area, it had the referral pattern, but they didn't recognize it was there in the first place. A primary trigger point can arise in response to trauma or acute or chronic overload. So as a result of, a muscle being overworked. A key trigger point that is, it's one that activates other trigger points. So this is the other thing that's rather interesting. When we look at key versus satellite, we can have a key trigger point that occurs, but it can start to affect other muscle tissue, which results in satellite trigger points occurring within the referral pattern. So key trigger points that activate other points. So satellites are activated by a key trigger point by being in its area of referral, or it could be an antagonist to that muscle or a synergist. So, satellites can exist within it. Central is located near the center of the muscle fibers. Attachment trigger points are located at muscle tendons or aponeuroses. Now, I believe that there are other causes. In my experience, when I would work in the neck, for example, and you have a synovial joint in the spine, which we'll talk about this week, I find that the fibrous capsule within that has referral patterns, and I've worked with those and gotten great relief as well. These reference charts. So we talked a little bit about that in clinical anatomy, and some of you, I think, went out and bought those charts, which is great to have. The thing that I said, though, to remember is that you want to make sure they're what's called Travell is the author. Those are the ones we generally tend to follow. So some ones to consider for this semester. Upper trapezius refers to the temple in a question mark pattern, and you will be getting these in clinical anatomy as part of the slides. SCM has a particular trigger point to above the eyes, throat, and external auditory meatus. Splenius capitis goes to the top of the head. Rhomboids, you're going to get that more in semester 2 because that's part of the appendicular skeleton. You've got local referral to the medial border of the scapula. Pectoralis major and minor, you get referral to the deltoid region. And for example, gluteus minimus, which is one of the small muscles within the gluteal region, refers down the posterior leg to gastrocnemius, which is one of the calf muscles. And as I've said many times to you, knowing these referral patterns will help you immensely in terms of assessing your client's pain patterns and problems. So again, we can see here's upper trapezius here. We can see this question mark that occurs. Again, we'll be talking about that in class. Myofascial trigger points. If a client's treatment plan indicates the possibility that a trigger point can be present, we have to identify it with palpation, and it has to have at least 2 of the following to say it's a trigger point. It has to have local tenderness within a taut band of a muscle, a local twitch response and or a referred pain tenderness to that very specific pattern, and or autonomic phenomena. So we have to understand that, we have to have 2 of these. Quite often students will say, I felt this taut band, it must be a trigger point. Well, just having a taut band of muscle does not qualify to define something as being a trigger point. You have to have at least one of the others besides a taut band to say it's a trigger point. And in my experience, it's always been that referral pattern. If you get that taut band and a referral pattern, you're pretty much likely dealing with a trigger point. The client then is informed that the treatment of a myofascial trigger point can be painful. And you're going to talk through the technique, but understand that, treating a trigger point is quite uncomfortable for the client. In other words, you need to get consent to work on that trigger point. Now, that could be right while you're working. If we go back here to the definitions, if you have a latent one that only happens when you're palpating, the patient may not be aware that they actually have a trigger point there, wherever there is and when you're working on them. But when you're applying your techniques, oh my goodness, you have found tenderness with a taut band and a referral pattern. So nobody was aware of it until you got in and started treating. So before you treat that trigger point, of course, you want to get consent. Is it okay if I do with that? Then you're going to get a pain scale to, say, I don't want to go beyond a certain number. Then you're going to check in and empower them, to make sure that it's working all right for them. All right. The treatment technique is applied until the client tells you the level of referred pain is either decreasing or is eliminated. Within our context as massage therapists, the 2 that are used the most are either muscle stripping or compression. In my mind, I've always only used compression. I found I've gotten the best out of it, but there is nothing wrong with stripping as well. If you were to do an oral practical and you had to do a trigger point and you did muscle stripping, you would achieve the mark no different than the other student who might do a compression. Discontinue the technique if the referred pain does not diminish. Follow the treatment of the trigger point. The treated muscle is then stretched. So once you perform the trigger point technique, whether that's compression or stripping, you then stretch that muscle, hopefully getting it into a new length that it was comparative when you first palpated. Now, it's not a CMTO standard, but some authors suggest applying heat after you have treated that trigger point and stretched it out. But you wouldn't be expected to do that at a CMTO oral practical. And so it's still out there whether or not hydrotherapy in heat, for example, actually works well. The client performs a concentric contraction of the target muscle to determine if the trigger point is dissolved or still present post-treatment. So you have them work that muscle to see if it brings back any of the symptoms. Not used or is modified if a contraindication to this technique exists. So, obviously spasm you have to be careful of, blood thinners and so forth. We stop the assessment treatment of trigger points immediately if the client says, I can't take that anymore, it's too much for me, and stops. So how do we do it? The first is we warm up the tissue with a specific technique. We have to consider our principles here, right? Superficial, deep, superficial, general, specific, general, because this is a very specific treatment. So we want to do general work first. We then identify that taut band and or tendinous nodule twitch autonomic response or referral pattern. Remember, it has to be at least 2. We then set a pain scale out of 10. So we might say, you know, I don't want to go above a 7 out of 10. If it gets above 7, please let me know. And then when you perform the technique, of course, you would ask, on a scale of 1 to 10, how are you feeling, you know, the discomfort? You then use a reinforced finger or thumb or an elbow. Stay away from elbows for now. You haven't got enough feedback yet. In fact, only certain muscles I would use an elbow, and that would be very large muscles. Traditionally, I always used my thumb and reinforced it with my other hand. Apply the pressure slowly, increase the pressure gradually, sustain evenly, and when you're done, you release gently and gradually. So slowly in, increase gradually, sustain evenly, and release gradually. Here's one thing this is what happens all the time. You'll pressure in, increase gradually, and then sustain. And you will feel the resistance of the tissue against you, and the patient will say, yes, that's a 7 out of 10. Then all of a sudden, the resistance will disappear. And the patient will say, there's no pain anymore. And then you would release gradually. This is generally what tends to happen. You get that release of the trigger point, and that's all good. You hold from a few seconds to more than a minute. As a new therapist, you might try to get in 15 to 30 seconds. Work at a tolerable pressure for you as the therapist. And then when using to treat trigger points, progress by increasing pressure in response to verbal feedback from the client and palpable tissue softening. So we go in slow, increase gradual, sustain evenly. I liken it to like layers of an onion. It could be that they've had the trigger point for so long that you are causing the discomfort by just pushing on the first layer of the onion because it's been around so long. That first layer then relaxes, and maybe you want to push into the second layer because the first layer let go. You go just a little bit deeper, you feel that resistance, you hold it for the appropriate time. The patient says, I'm no longer a 7 out of 10, I don't have pain anymore. You as the therapist have felt the tissue relax. Maybe you go in one more time. So you go in a third time, and the third time, it just doesn't give in. There's pressure there the whole time. That's when you're done for that treatment. You release off, apply your principle, you work deep, now you're going and specific. So now you're going to go general and superficial to finish it all off. Apply that stretch and so forth once you've done the trigger point. When using to treat trigger points, progress by increasing pressure, as I said and I just explained. After the trigger point's been released, when the client has given the feedback of no pain or if the trigger point doesn't change, we stop the trigger point release. We stretch the identified muscle passively for 30 seconds. In other words, taking the two attachments away from each other. And again, it's not a standard, but one of the recommendations is to apply moist heat to the muscle for 5 minutes or longer. We continue with our regional massage. We flush the area with petrissage techniques and to try to get all the junk, as that video alluded to. You're getting all the crap out of the trigger point. You want to flush that all away. And then, of course, you have the client perform full active range of motion after you've done the massage and the treatment. So what do you need to know? Know your referrals of common trigger points. Identify key trigger points and perpetuating factors. That's why I have in the slides, chewing gum, doing other things can cause problems because all we've done is muscles of mastication. Use stripping and specific impressions on trigger points. Proceed and follow with regional massage. Again, specific, deep, specific, general, specific, general, and superficial, deep, superficial. We got to keep those in mind. Trigger points can mimic nerve entrapment, nerve root pain, and visceral pathology. So quite often, the patient's been to many, many other types of treatments with very specific diagnoses, and they haven't turned out to be correct. And it turns out that they actually have a trigger point that's causing it. Trigger points can cause excruciating pain, so we have to be careful with it, but we can resolve them, hopefully. Definitely make sure you treat the agonists, antagonists, and synergists within the context of that identified muscle. Follow with heat, stretch, and active movement through full pain-free range of motion, and teach the client self-care protocols such as strengthening the weak structures, and again looking at things such as ergonomics at work, posture when sitting, standing, and so forth. Draping, we'll see some videos this week, but when we look at positioning, we always need to consider safety. What are your treatment goals? Areas you wish to access, and the client's preference and comfort. So we always consider that. Options, of course, are prone or supine, Side lying, semi-seated, seated, and semi-reclined. We'll be going over those next week. Client comfort, of course, is at the utmost, so that could mean that you have to either add or remove pillows, bolsters, or towels, and you're always working within the client's requests and comfort levels. The draping places client in a safe, warm, modest, and comfortable position. Obviously, you need consent and permission in order to perform that draping. You'll let them know within the consent what areas of the body you'll be exposing and so forth. You maintain appropriate client-therapist boundaries. Comfortable yet precise and secured when the draping client for treatment purposes, so that, you want to make sure that everything's correct. I talked a bit about that in class, that you don't want wrinkly sheets. They do get uncomfortable. Know your standards of practice. And within that context, you have to consider what are identified by the CMTO as sensitive areas, such as breast, chest wall, upper inner thigh, and gluteals. And it doesn't matter what gender it is, it has to be for both genders. Explain draping procedures carefully for clients during consent and written for sensitive areas. Again, you're informing them to get consent to provide the type of draping you wish to do. Know how to modify draping procedures for different practice situations. That's why you're going to learn all these different draping techniques as you work your way through. So you can see here, these are particular landmarks and so forth. We're going to go through next week with the videos and sort of review them. And I know you've already been practicing a lot of these in the lab. Hopefully you go into open lab and practice them as much as you can. Okay, obviously this is all chapter 9. And thanks very much for listening. That's the end of the screencasts for this week. And we'll be back to class next week doing things as normal. Thanks again. Bye for now.